I'm Dr. Wang. My topic is Cerebral Venous Thrombosis, CVT, the Incidence and the Management. I come from Taiwan. I'm very happy to give the talk. These are my disclosures and my outlines. CVT is a very infrequent condition encountered clinically with an annual incidence about 3 to 4 cases per 1 million population. Female has a higher ratio than male, and it is found SRH is one of the risk factors for the development of CVT. The incidence of CVT is about 1 to 2%, according to several large studies published earlier. And in our study, we also found 1.8%. And if you see the female to male, the ratio is about the same because the number is too few. So it cannot be judged just from the total numbers. And we also found in our study, female, according to their ratios, is a little lower than males. There is no statistically significance because of the low number. We know the cerebral venous related signs are very important and diagnostic in patients with SIH, like diffuse pachymeningeal enhancement, venous distension sign of lateral sinus, and also the pituitary hyperemia. Therefore, the putative mechanisms of CVT in patients with SIH might be related. It is known that the reduction of cerebral spinal fluid in the brain will be compensated by the engorgement of the venous system by the Monroe-Kelly doctrine. So the venous volume is increased, and because the flow velocity of the venous system decreased, which might increase the stagnation or coagulation of the venous blood and causing venous thrombosis. So who should be suspected to have CVT in patients with SIH? The most frequent symptoms are blurred vision due to intracranial hypertension and pupil edema, new focal neurological signs, altered consciousness, and I believe seizures are the most important. In our hospital, we collected 8 cases with SIH and CVT. We found none of them had blurred vision, but 1 case with new focal signs and 3 cases with seizures. This is our first case published earlier, who has CVT and SIH. This is our first case, a 33-year-old female patient with SIH complicated with CVT. And in her MRI, we found the SIH in the sulcus. And we also found the vein of Kohala on the left side with CVT. The patient presented with a neurological deficit and also seizure. How to diagnose CVT in patients with SIH is very similar to diagnose CVT generally. I believe the MR venography and the CT venography are the hallmark for the diagnosis. On the left-hand side, you can see this patient with superior sagittal sinus thrombosis here and here, and you can see the typical empty delta sign in the patient. On the right-hand side, you can see the deep cerebral venous thrombosis, including straight sinus and vein of Galen here. And because of the thrombosis of these vessels, you can see the swelling of bilateral thalamus. The 3 major treatments for SIH complicated with CVT, including epidural blood patching for SIH, anticoagulant therapy due to CVT, and also anti-epileptic drugs for seizure. This is our flowchart for treatment of SRH. When we see a patient with SRH, and we try to do the localization as soon as possible. After that, we do targeted epidural blood patch. Sometimes we may need 2 to 3 times of epidural blood patch if the first trial does not succeed. This is how we did the directed epidural blood patch by anesthesiologists. After we localized the leakage by the MR myelography. How about anticoagulant therapy in patients with SIH complicated with CVT? First, there's no RCT studies in these cases because of the case number is very few. The second thing is we don't know if it is similar for anticoagulant therapy in these cases and the general CVT cases. There's one study just published 3 years ago about the randomized controlled trial with the probe design to compare dabigatran, the new anticoagulant, and the traditional warfarin studies. The study design with a screening phase on parenteral heparin followed by either dabigatran 150 milligram 2 times a day or warfarin based on INR for 24 weeks and another 1 week for follow-up. The study showed that the effectiveness was similar between the 2 groups. That is, there's no venous thrombotic events in both groups. And the safety is also very similar with 1 major reading in 1 case in the dabigatran group and 2 cases in warfarin group. What is provoked CVT? You have to find out the risk factors. And in fact, I found that lumbar puncture is also one of the risk factors for CVT, which can be considered to extrapolate to our condition, the SIH. Based on the AHA and ASA guidelines, CVT may be considered as a provoked CVT. The anticoagulative, the treatment duration is suggested to be 3 to 6 months. You can see on the right-hand side, treat underlying cause. In our situation, this will be the SIH, which is solved by epidural blood patch. And it is suggested to do the 3 to 6 months treatments with anticoagulation for provoked CVT. In such cases, will be the SIH. How about the seizure treatments? Do we need prophylaxis? The data are very limited in the prophylaxis of anti-seizure medications in patients with CVT. A multi-center prospective observational study with CVT, they found in patients with supratentorial lesions and also presenting with seizures in patients with CVT, the odds ratio is very low and statistically significant. So we can use this study results to consider to use anti-epileptic drugs to prevent early seizures in patients with CVT for those with supratentorial lesions and those who presents with seizures with CVT. So what is the duration of anti-epileptic treatments? There is no evidence to provide any guidelines, but a study showed AED needs to be used for 1 year when the seizures are associated with brain abnormalities, including brain edema, infarction, or hemorrhage. What's the prognosis of the patient with CVT? Most patients have very good prognosis. In this cases, you can see that even though they use anticoagulants and epidural blood patch, anticoagulation alone, epidural blood patch alone, you can see there's no any differences. We only see 1 case, a mortality that's only use anticoagulations. So in my opinion, probably this is the best anticoagulation and epidural blood pressure at the same time. In our 8 cases with SIH and CVT, the prognosis is very good. They receive 1 to 3 times of EBP, and they showed recanalization in all of them. 4 of them received warfarin treatments, and 2 patients received anti-epileptic treatments. This is my last slide. CVT is a real complication for SIH, about 1 to 2%. There's no sex predominance. MR venography is very important in the diagnosis with CVT. Patients may present with seizure and new neurological symptoms. The treatments includes EBP, the best with the directed EBP or targeted EBP. The second one is anticoagulant therapy. You can use warfarin or NOAC. The effectiveness and safety are similar and can be used for 3 to 6 months, because I consider SIH is also the provoked cause for CVT. Anti-epileptic treatments is suggested to use in patients with supratentorial lesions and presenting seizures. Most importantly, the prognosis is very good. We still need data to have a conclusion to treat these patients. I have to acknowledge my clinical and the research group in the research and the clinical service for SIH. This concludes my talk, and thank you for your attention.